Qual a melhor cirurgia de mama? Qual a melhor mastopexia? Qual é a melhor técnica? Qual é o melhor implante? Será que a gente precisa usar tela? Muito bem-vindos a mais um episódio do podcast da BAPS, do 4º Congresso Nacional da BAPS. E eu tenho a honra de estar aqui com dois convidados que são extremamente habilidosos, que sabem muito bem o que estão fazendo. Um convidado especial que veio de fora, que é o nosso querido Giovanni, porque ele é italiano, apesar de morar na Espanha. Então é uma honra. It's very nice to have you here. Thank you so much.
Thank you for having me.
E a gente tem um convidado especialíssimo que não é de outro país, apesar da língua ser parecida com o português, que é o mineirês, que eu sou apaixonado, porque meus pais são mineiros, certo? Minha família é toda de Minas. Doutor Adriano, é uma honra te ter aqui mais uma vez.
Obrigado.
E é interessante porque nós vamos poder falar um pouquinho de técnicas diferentes, técnicas que a gente não tem visto na maioria dos colegas brasileiros e que a gente precisa saber indicar a técnica correta para cada pessoa, ao invés de a gente querer defender apenas uma técnica. Pelo menos essa é a minha visão, e eu vou abrir esse podcast perguntando se eles concordam com isso. So, Giovanni, again, it's very nice to have you here with us. It's an honor for us. And I was introducing the podcast, saying that I believe, it's my personal belief, that the good doctors, the good plastic surgeons, must know the best technique for each patient. I don't think that there is only one technique that's the best for everyone.
Of course.
Yeah, do you agree with that?
Can you talk about that? I completely agree. And because the patients determine, the technique we have to use with them, because it's their body shape, the amount of glands, the strength of the muscle, and the amount of fat that actually determines the way we work on them. So I totally agree. I mean, there is not one plane that you have to use. There is not one scar that you have to use, and we're good when we adapt ourselves to the patients.
Nice. E você, Adriano, você concorda? O que você pensa sobre isso?
This is something I usually talk about. We need to be versatile. If you use only one technique, you're not going to be the best surgeon. Perfect. You're not going to offer the best surgery. So we need to know all the techniques and use the best one for each case.
Very
this
nice.
is something I defend.
Yeah, and it's nice because in Brazil we have a lot of WhatsApp groups of plastic surgeons, and we are always arguing and talking about the techniques and what is the best. And I see a lot of times that you defend a lot of good things that many doctors, many plastic surgeons doesn't know how to do, or they are not experts in that. So I've been seeing a lot that many times you use polyurethane.
Yes.
Am I right?
Yes,
okay.
yes.
So how do you decide to use polyurethane or use like a microtexture or a smooth implant?
As I talk a lot about polyurethane, everybody thinks that I use it in the majority of the cases, but it's not a reality.
Oh, nice.
I use in 12% of the cases in situations that I have a muscle, an instability of the implant, usually in secondary surgeries. And it's very useful in a simple way to solve these problems, because we under the muscle in dual plane situations, the polyurethane is very stable, and I don't need to use the mesh.
Yes.
So it's a possibility. It's cheaper, it's easier, and I've been doing this for 13 years, a long follow-up, almost 100 patients. So I think it's a secure way to solve these problems.
Oh, it's nice.
But I usually use microtexture
like
implants.
90% of times.
Yes.
80 to 90% of times.
90.
Microtexture. You don't use smooth implants?
No. I tried, but I was not so happy with the results.
Okay, perfect. What about you, Giovanni?
Yes, well, I agree with what he says a lot about the polyurethane, because I've been using polyurethane quite a lot as well. Even I use mesh now. It's because I also do breast reconstruction. So when I do DTIs, direct to implant reconstruction, I basically all the time use polyurethane. And in my aesthetic practice, I mean, in the cosmetic surgery, I use polyurethane in quite, recurrent capsular contracture cases like secondaries. And I use polyurethane when the patient, I'm an anatomical implant lover, so I use polyurethane anatomical implants in those patients who are very sporty, like a sporty lifestyle, and they want augmentation with anatomical implants. Then I would go for the polyurethane. And yes, my Mastopexia technique is not with polyurethane, but now I'm starting to do a little study to see which is best. The only thing is, if we go through the technique, I do believe that if you do a Mastopexia with polyurethane, you need to get rid of much more gland, of course. Otherwise, you would have like a waterfall effect. And my technique save quite a lot of glands to give a more natural.
In your view.
No, but not even. I mean, it's like in a more natural kind of result. So that's why.
So
and then yes, sorry. And then I also use microtexture a lot, implants, and then I also use semi smooth, or not fully smooth because I don't like them. But this kind of nano textures, or I do use. I have been using it in very special cases. It has to have the perfect
indication.
Exactly, it's perfect small breast to do like this easy and nice augmentation. And then I would use that. But again, when I first began to study the effect of the safety and the efficacy of the meshes, I did it with semi-smooth implants. I did like subfacial positioning of semi-smooth implants and mesh, just to see. I think I can't think of any better way to test the effectiveness of stability of the mesh. Yes.
Perfect. So, do you consider you a romantic guy? A romantic man?
I'm Italian. I'm very romantic.
All Italians are.
So I believe that maybe that there is some influence in the name of your technique about Mastopexia. You see, because can you talk a little bit? You told me, and I want to congratulate you because you recently have read a paperwork approved at the PRS. Talking about your Mastopexia technique, it's a flower Mastopexia.
Exactly, I call it
a romantic guy. So can you talk a little bit about?
Yeah, you give flowers to the ladies.
Yes.
So I give a flower Mastopexia.
Nice, nice for the social media.
Exactly. No, actually, there is a reason why I call it flower, but it's in the drawing. Well, not in the drawings, because the drawings are very basic, because I just need some reference point, and then I tailor tack the Mastopexia and the gland and the skin on the way. So it's not like the predetermined cut that I do. It's like on the run. But there is one point after I've done the vertical excision that before doing the actual horizontal excision, it looks like flower on
T junction.
Yes, exactly. And it's a little bit of terrace of ground, just underneath it, that mimics the vase of the matzet. I don't know how to say. Yes. Exactly. And so it looks like a flower.
Yes.
Stuck in the ground, So, and then when you use the mesh to stabilize the thing, since the mesh is brownish, let's say, so it looks like earth. It looks like the ground. So it gives this effect, but it gives a bit of fantasy.
Perfect. I don't know what's the technique that you are using more in Mastopexia nowadays.
The vertical excision,
primary
and short scar.
Short scar.
Yes, I prefer them. The L.
The L. Okay, nice.
Tomorrow I'm going to talk about this with layers.
Okay. That's very important, because I think that all the techniques are good.
Yes.
Of course, we have to know the indications, and of course we know which one is better in our hands.
Yes.
Right. So I think that's the most important, because I like to say in all my time with my patients, I say I'm not just a surgeon. I take care of people. take care of lives. So I have to know what is better for you in the way that you think it's better for you. So many times this car depends on what the person wants.
Yes.
Right? So have you been using the mesh, any kind of mesh? What do you think about that?
No, I never use the mesh. I think I will try someday. But as I'm usually use the polyurethane, and it's a good solution for me.
Yeah.
For 13 years. So I didn't feel the need to use meshes till now. Nice. But who knows?
Yeah.
Feel convinced.
I myself, we are always talking about the internal bra in Brazil. I don't know in Spain.
Yeah.
It's a lot of internal bra. Everybody wants. The people comes to to the office saying, "Do you do the internal bra?" So in my view, it's a little danger ground here, but I think that maybe the mesh is the real
internal bra. Yes,
exactly.
So what do you think about that?
Yeah, I totally agree with you. As a matter of fact, we just we sell it to the patient like I just make me put an internal bra inside you, just to hold it in place, and it's not a push up; it's just an internal bra, just to stabilize the lower pole. And but yes, when we need a study. We can do it together. We need a study comparing, Mastopexia, but we should use the same technique. But using the Mastopexia with polyurethane, and the other one with mesh. Yeah, going subfacial.
A little problem we have here in Brazil is about costs.
Yeah.
Yes, because in Brazil,
they're very expensive.
Costs like 10,000 reais. The one that you use, I use the same way. I cut a little bit different from you see, but you can divide in two, so it's not so expensive. It's expensive for most people, but it's not so expensive. If you use the 3D Galaflex, then it's 30,000 reais, so it's more than
and you have to buy two.
Yes, it's 15, so you have to buy two, so it's 30, and
it affects
most of the
final cost.
Most of Brazilian surgeons they don't charge 30,000 reais for a Mastopexia.
Right,
it's a problem.
So that's a little bit difficult. So you have been using it like for 5 years. Am I right?
Yes, it's a bit more now, but I've been studying a lot. So because we came out with some. Now there are like mine and with collaborations with like 6 articles about Galaflex. Yeah. So we have it studied quite a lot. Of course you need longer follow up because but and in terms of safety, I'm sure it's safe. I mean, I haven't had any problems. I think
you didn't.
No, I didn't. No, I don't even use drains. And one, I had a little exposure in the T-junction. Yeah. And just one time it just healed by itself. The other time I had to trim only a small triangular bit, and then it closed up. So I didn't have to go back to surgery for that.
Not even to change the implant.
Not even to change the implant.
Nice.
Didn't have the exposure of the implant. We have the exposure of, but then it integrates immediately. So I feel it kind of safe, and the patient, it reabsorbs, so the patient doesn't feel to have like a foreign body inside, which is also very important. Mm-hmm. And we have to think about it as a sort of rejuvenation kind of for the lower pole tissue, mm-hmm. So you just creates this kind of fibrosis and collagen, which makes it a bit stronger.
Okay. Adriano, do you agree with me that in Brazil, women, they really want very high breast,
Brazilian, right? They don't like natural results.
Most of them doesn't
Most
like.
of them.
So my question is, because of course it's a matter of opinion. Some people like natural, some people like artificial. In Brazil, many times when they say I don't want artificial, it's because they don't want very huge.
Okay. Yes.
But they want artificial, you see?
Yes.
Very high and very...
When they say natural, they're talking about cleavage. And...
Yes. I want a very, very marked cleavage. Yes. I want very round, but I want natural.
Yes.
So how come
I want
that's
big.
Not natural, you see? So
I don't want big and I don't want small.
Yeah. So they want natural. When they say they want natural, they want good volume, but not huge. You see, but I've been seeing a lot in many places that we go, like in Europe or even in Asia or US. They don't want a very high breast. Okay, so. Do you think, because you perform a subfacial mastopexy?
Yes,
That's your preference.
Most of the times, yes.
That's your preference.
When I
so,
can.
do you think that is it possible to make many Brazilians happy with this technique?
Not really.
Perfect.
No.
That's why we changed to dual plane.
Yes.
I did subfacial for 15 years.
Yeah.
And it was a demand of the patients to cleavage, higher implant. So that's why we changed for dual plane position.
That's very important.
Yes.
That's what I want to talk about, because I really like that natural results. So do you think maybe you are free to say that I believe it's best? Okay, it's the best. Do you think that for natural results, the subfacial approach is the best one in your opinion?
That's a good question, because I think the softness and the palpability and the look, most probably, to my opinion, to my taste, it's maybe better. Okay, but then again, if you do a dual plane, well done.
Yeah.
Okay, you can have like a little bit higher cleavage, but
natural result.
But natural,
Yeah.
and with the nice upper pole slope and nice fullness of the lower pole. So it depends how you do things. But I do believe that this kind of procedure is talking about the feel of the breast. It's better than going completely retropectoral, for example, retromuscular. I do believe that.
Okay. So in your primary mastopexy, do you always go dual plane?
Nowadays, yes.
Yes.
The last 6 to 7 years,
Yes.
always.
It's the same of me. I think it's the same of me. But now, because
You're turning back.
No, I'm not turning back. I really think in Brazil, it's very important to do the dual plane, because they want this high,
Yes.
the high breast. So they want that high cleavage. But I've been receiving more and more patients that want natural results because of the new technique that preserves the ligaments. You see?
Yes.
So I'm not allowed to talk about it, but the name, you see. But because of that, we have a little bit more options with the preservation mastopexy that we use this technique. You see, so I'm a little bit more open again, because I'm not closer to the subfacial. I have my father-in-law. He's a plastic surgeon too. He's here, and he loves the subfacial plan. He's always talking about the subfacial plan.
Yeah.
So I think it's important that we are. How can I say? We are bringing back this, and I think that's why we are talking here. We three are talking here in this place.
But as you said, the problem in Brazil about dual plane is that the younger surgeons are trying to perform in 100% of the cases, and in my opinion, it's more difficult, and the complications are worse to deal. So we've got today a real secondary market.
Yeah.
It's not bad for us.
Yes.
Exactly.
But
Recurrence.
yeah, yes. But this, I think, it will stimulate the coming back to subfacial situations. For in the learning curve, it's better to start in subfacial. Younger surgeons than dual plane, and this is not happening in Brazil.
Yeah, no.
Everybody wants to do dual plane.
Yeah,
so.
everybody's like graduating and doing AD, liposuction, 360.
Yes.
With intramuscular grafts, everybody wants you to do everything, and that's not quite safe. I agree with you. I saw your presentation yesterday. It was a pleasure for me, and I saw that it's not it as you say, you do the marking through the surgery.
Not a previous mark.
Exactly.
Yeah,
Exactly.
And that's very nice. I do the same. I do the same in a different way, but and I see that many times when we do like that, I think that's a risk of the scars become a little bit more longer. Do you agree that? How do you do to with your technique to make smaller scars, or you don't think about that? You think I have to give the best result, doesn't matter the size of the scars.
Exactly. That's the point. I mean, I think the scar is important, of course, but the result is more important. Okay. So, in my technique, it's a tailor tack, so you can actually grade the tension. So it's good for the healing process. And then, according to your taste, the horizontal excision, which gives like the dirty T scar, I mean the scar in the IMF. Of course, I try to make it as short as I can, but sometimes if you have a lot of laxity or a lot of loose skin, you have to make it a bit longer. But usually with this technique, you never get to a visible cleavage scar, which is quite good. Of course, a different concept from the L scar, and but yeah, well, you need to get rid of as much skin and gland as you possibly can to give the better results, and it doesn't matter the scar, really, to my opinion.
And then the nipple, let's talk later, like the nipple, the complex scars. Do you have good results with your technique, both of you, or maybe many times it's an issue you have to correct that again?
I think the ones that are looking for smaller scars all the time will have nipple problems. So I try to always, my priority is the shape, not the size of the scar. Of course, I always try to make it smaller, but the shape is the most important for the patients, for the long-term results. And when you try to make it slower, you need to compensate with the areola.
Yes.
And that's a big problem.
Yeah.
Because they will be bigger, they will be asymmetric. So I try to don't make it too large. No, not much compensation. So it's not my priority, the
size of the scar.
The size of the scar.
Perfect. Yeah, I think that we're starting to think about that more again, because
yes,
and of course it's always the market. You understand me? The market is like what people want. I'm talking about money directly, but people want what people demand. So demands short scars. So we have to know how to do everything with the short scars. But many times we say, but I cannot deliver the good result with that short scar in this case. So
I was talking to Ono.
Right?
Ono told me, Marcelo Ono told me a few days ago that he started to make it longer because the nipples were so.
So do you have the same impression?
Yes, I mean, I tell you a short story. I mean, some years ago, we had a fantastic plastic surgeon, let's call it like this, in where I work, that actually sold all the Mastopexia. I'm doing the shortest scar possible. I can do everything with round blocks and blah 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 to every patient. And there was a time that patients were coming to me only asking me, can you do it without the vertical scar or without the italic? No, I'm sorry, I can't deliver that kind of result only with the period. And so they said, okay, thank you, and they went back to the other guy to do the period.
They came back later,
and then they came back later with sometimes impossible to correct results. Because of course, as he was saying before, the scar in the nipple goes great, larger and larger and larger. Then you have to revise it most of the time in the office with local anesthetics, and the patient have pain, of course, and then again to be wider again. I mean, it's like
it's a difficult complication to solve.
Yeah. When it's not indication, it's not indication. You have to cut through the vertical. Well, you do it.
A man has to do what a man has to do, right?
Exactly.
Yes.
So I would like to ask you a final question. It's two questions in one. What are the great benefits and the great risks that in your technique, in your Mastopexia, in your flower mastopexia? What do you think is the great benefits that you offer and the biggest risk for the surgeon? For the
That's
person?
tricky. I mean, the greatest benefits to my view, it's softness, natural look, no pain whatsoever. It's the fastest track you can think of because you don't touch the muscle. There's no pain. At the end of the day, I mean, you have a virtually no breast animation, which is another problem of going below the muscle. And of course, in the proper technique, flower mastopexy, you use a scaffold, so the cost is a bit higher. So that's that's a disadvantage. Yeah. And then it depends on the skin. I mean, if you have a very, very loose with skin with soft tissue quality, poor soft tissue quality, or big stretch marks, the risk of bottoming out, even though you use the mesh, it is possible. So there are some pros and cons. Yes. But I go subfacial whenever I can. To me it's enough a 1.5 centimeters pinch. So.
And if you have a secondary case, patients that you did, and you've got a bottom condition, you change the plane for dual plane, or you try again the approach.
That is the case I'm showing in a few hours, which is secondary mastopexy, and the case was of a lady that was operated 4 times from the same surgeon. Who thought that to maintain the periorbital scar, you just had to go bigger, subfacial bigger, and eventually the NIC would lift up, which is absurd. And so then I changed it. I went to
dual plane.
Yes, I did the flower, but dual plane.
And the re-op when you use Galaflex, the re-op condition is okay. No difference.
No difference. No. It's like
nice.
As I said. The mesh
is absorbable.
In 2 years, it's gone, and in a month, basically, it's almost fully integrated already.
Okay.
So that's why you don't have that kind of dead space that can provoke seromas or things like that. So I haven't seen red breast syndrome, or I don't use drains.
Yeah,
nice.
Don't use to.
Yeah.
And what about your technique, Adriano, that you do in most of cases? What do you think it's the best that you can offer, and what the disadvantages or risks to the patients?
The best thing is to control the stability of the implants. Whether I use microtexture or polyurethane, it's a well done dual planes. It demands a longer curve, so it's a difficult technique, not so easy as for beginners. But in my opinion, it's a better way to preserve longer results. Nice. Especially when we talk about cleavage, our natural or not natural
Brazilian natural
Brazilian natural results. And the biggest problem is the waterfall condition. I think we need to remove more tissue, because when you do, especially in reduction, something I talk a lot, when you use dual plane in breast reduction, if you don't remove a lot of tissue, you will have waterfall condition in 3 months. Yeah. So we need to think. Yes, the big challenge. In this condition, it's better to use subfacial if you're not going to resect a lot of tissue, because everything goes down.
Yeah, together.
Yeah.
Perfect. Então é isso, pessoal. Eu quero agradecer a vocês que estão assistindo e fica um último conselho, se é que eu posso dar algum conselho para quem está assistindo, né? Se você ainda não tem muita experiência em cirurgia de mastopexia, está começando, mastopexia, na minha opinião, é a mais difícil, ou pelo menos uma das mais difíceis cirurgias da cirurgia plástica no momento, porque a exigência é muito grande e as técnicas são complexas. Então, se você quer ser realmente muito bom em mastopexia, não assista apenas esse podcast, assista muitas aulas, faça muitos cursos, procure acompanhar pessoas que são boas naquilo que você quer ser bom, e que Deus te abençoe, que você faça muitas pessoas muito felizes com as suas cirurgias, e lembre-se que você tem que cuidar de pessoas e não apenas fazer cirurgia. E até o próximo episódio.